Today we will talk about odontogenic infections. So we're going to talk about it in general and see how to manage it when it comes. First, we'll talk about introduction, laboratory investigations, diagnostic imaging, principles and management, and the use of corticosteroids. So, infections of dental origins are among the most common infections worldwide. Now, the major cause for odontogenic infections is usually the oral microflora. The normal bacteria that's found in the oral cavity, they will cause the infections. But once their load becomes higher than what the body can fight, odontogenic infections happen. Now they it fluctuates with age, disease conditions, and where they reside. Streptococci represent almost half of the viable counts, and usually the infections are polymicrobial, meaning multiple types of bacteria, anaerobic and aerobic. The more causative factors are the gram positive cocci and the gram negative rods, but the streptococci being the most prevalent, and mostly they are anaerobic in origin. So the bacteria will be anaerobic gram positive or negative cocci and rods. So the most frequent pathogens are usually as the Streptococcus miliary group and the Peptostreptococcus species, about 65%. The Provotilla species, Oralis, Melanograngia, 74%. Now, once we have a patient with an odontogenic infection, we need to ask for some lab work, whether it's submandibular, if it's buccal, if it's more submental, whatever it is. Now, usually we order a complete blood count to see the white blood cell count. Usually it will be higher. Inflammatory markers such as the CRP and the ESR, but these are not adequate. They will just tell us that there's an inflammation, but they will not tell us what's the bacteria causing it, what is the cause behind it, what's the tooth that's causing it. They will not tell us any of that. They will only tell us if they're raised, there's an inflammation, there's an infection in the body. We need to find out what it is. After taking the lab work, we need panoramic x-ray to see the tooth that's causing the problem, ultrasound or CT with contrast. If we can do a CT with contrast, that's the most accurate one because it will tell us where the collection is, if there is a collection, if there is pus, and where is it and how deep it's reaching. The neck ultrasound will just tell us if there is an infection or not. It will tell us there is collection or no collection in a specific site. But if it's deeper, if it's moving towards some place else, they will not be able to tell us this process. Now, the principles of management. Usually, we determine the severity of the infection first, evaluate the defenses, decide on the setting of care, surgical management, medical management, antibiotic therapy, administer the antibiotic properly, and we evaluate the patient. So, first, we need to determine the severity of the infection. Now, there are three major factors that we have: the anatomic location, the rate of progression, and the potential for airway compromise. So, the anatomic location, we have low severity infections like the vestibular space infection, canine space infection, buccal space infection. These are considered low severity because they only affect the local site. There is no threat to the airway, there is no threat to vital organs. Now, the moderate severity, like the submandibular space, the pterygomandibular space, the submacetric, superficial and deep temporal spaces, submental, sublingual spaces, and so on. Now, the high severity, like the lateral pharyngeal or the retropharyngeal, the danger space, and the mediastinum, these are considered high severity and there's a very high threat to the airway. Okay, so these are the infections that we might face. Now, the infections that goes through three stages. The first stage is the edematous stage. The second is the cellulitis stage. And the third is the abscess stage. Now, in the edematous stage, usually it starts within the first 3 days. The pain would be mild to moderate, usually small, diffuse, fluid like structure, and aerobic bacteria will be the predominant part there. The appearance, the skin, everything will be normal except that it will be slightly heated and edematous. In the cellulitis stage, it will be hard, erythematous, and usually happens within the 3 to 7 days after the infection. It's the highest risk because it can spread to places that we don't want it to reach there. Meaning it can reach the lateral pharyngeal, it can reach the retropharyngeal from the submandibular part. So it's large, diffuse, very tender, erythematous skin, and mixed bacteria. The abscess stage over the 5 days, here the body has dealt with the infection and it localized it in a specific place. So we will find pus, anaerobic bacteria. The center of it will be undermined and shiny, and it will be tender and fluctuant and peripherally reddened. Around it will be red, but in the center will be shiny and undermined. Now, to know if there is an airway compromise or not, we need to look at some structures. Trismus, if the patient cannot open his mouth properly. Up to now, we usually open up to 44, 45 millimeters. Can be raised, can be less a little bit. But if the patient can open 2 finger widths or less, this is trismus. Here I will suspect pterygomandibular space or submesenteric space. Dysphagia or dyspnea, difficulty in breathing or difficulty in swallowing. These are signs that the patient might have an infection. The patient might have severe infection that's reaching the airway. And pulse oximetry. If the patient has a pulse oximeter less than 94%, there is some airway compromise. Now here we can see a right vestibular space abscess. We can see the area reddened, and here mostly the cause will be the lower 6 or the 7, as the picture cannot see proper stuff. Now here we can see a buccal space infection due to an upper tooth. Now why would I say it's due to an upper tooth? Because it's closer towards the eye. So it might be the upper 4 or the 5 because it's closer towards the eye. Now this can be considered a buccal space infection as well, because here there's a slight swelling. Now here this one is due to lower tooth. As we can see, it's not reaching up. This one is reaching the maxillary part, so we would suspect a maxillary tooth. Here is a canine space infection. As you can see, the eye has closed due to the swelling that's around it. Here we have a palatal space infection. Now this usually the most likely cause would be the upper lateral or the palatal root of the 4 or the 6. Now here's a submandibular space infection. Now how can I define a submandibular space from a buccal space? Now usually I would be able to palpate the lower border of the mandible in the buccal space infection. So when I try to palpate the lower border, I will find it palpable. This means it's a buccal space. If I cannot palpate it, I cannot feel it, it's submandibular space. And here's a submental space infection. Now here usually would be the cause would be the lower incisors. Now here we have a pterygomandibular space infection due to the lower wisdom. The lower wisdom is the most commonly involved in a pterygomandibular space infection. And here's a lateral pharyngeal space infection. So the second step that we need to evaluate the host defenses. We need to see the factors that have can reduce the patient's immune system. Like diabetes, it can reduce the immune system, cause the infections to be more severe with less pathogenic bacteria. Steroid therapy, they can put the patient at risk of infections. Organ transplants and chemotherapy, patients might be on some immunosuppressant medications. These are more susceptible to infections. Renal disease, patients already on immunosuppressants, patients can be on the body cannot tolerate infections well. So these are factors that can be associated with immune system compromise and malignancy, of course, as well. Now decide on the setting of care. I have two options. Either I will deal with this patient outpatient or inpatient. Outpatient in a clinic, I do the extraction, the incision and drainage, and send him home. Inpatient, I need to admit the patient. Now, there are few indications for admission of a patient. Temperature over 101 Celsius, Fahrenheit, which is 38 Celsius. Dehydration, patients not eating well or not drinking well. Here, this is an indication for an admission. Moderate or severe space infections, submandibular, submental, pterygomandibular, submesenteric. These are a threat to the vital airways, to the airway or the vital structures. Need for general anesthesia or need to control systemic disease. I need to control the diabetes of the patient or the hypertension of the patient. In this way, I will need to admit the patient. Now, treat surgical. The main way to manage any infections is to surgically remove it. First thing we do is check the airway, make sure the airway is patent, protected. Then we need to remove the source of the infection. If it's a tooth, we need to extract it if it's a severe case. If it's not so severe, we can do access. We can do incision and drainage with the access. And these are good ways to manage the infection. And culture and sensitivity, it's kind of mandatory, so we need to do that to know the antibiotic that we are supposed to give to this patient. Now, when to go for the operating room, when to go for GA, when we want to establish airway security, we want to make sure that the airway is patent, when we want to protect the airway, when we have multiple spaces involved, when we have a lot of spaces involved, and if we have moderate to high anatomic severity. Here I need to be very careful when I'm doing it. I need to be very careful when I'm doing the incision and drainage. Rapidly progressing infection, an infection that started 3 days ago, for example, and now the patient comes with a submandibular space. Here I need to do it properly as well. And if I find any need for general anesthesia, if I find that this patient is a kid, I will go for GA. Now, sometimes to manage the infections, we can do aspiration like this. We insert the needle into the space and aspirate to find the pus, and that marks the incision for us. And this can be sent for culture and sensitivity. Here, if you have a temporal space, that's the incision that we're going to take. For submandibular or submental or sublingual, we can do the incision below the inferior border of the mandible, 2 fingers below the mandible, because we want to protect the facial nerve, the marginal mandibular branch. Also, C can be used for submesenteric, sublingual, submandibular, pterygomandibular. D for the lateral or retropharyngeal space infections, and for the carotid sheath and lateral pharyngeal and the high severity infections, longitudinal incision. Now, once we're done with the incision and drainage, we need to do irrigation. Now, irrigation can be done with povidone iodine solution, normal saline, or hydrogen peroxide. Now, each has its own advantages. For example, normal saline is isotonic due to it has lower toxicity and physiologic factor. But the disadvantage, it does not clean dirty necrotic wounds as other solutions. The iodine has similar infection rates have been reported in adults and pediatric population with saline versus iodine. Now, the disadvantage of it, it has its cytotoxic to human cells and granulating tissues, and it might discolor the skin, but it's very good effective against Staph aureus. Hydrogen peroxide, it's very effective for debridement to lift debris and necrotic tissue out of the area, and it's very good, but it's not recommended in wounds with sinus tract. Sometimes we might place a drain like this to have a good way for path of irrigation to reach all the spaces that we want. Now, when do we do the incision and drainage? Once we find pus. We never let the sun set on an undrained abscess. We need to do incision and drainage once we find an abscess. Then we need to support the patient medically, hydration, nutrition, control of fever. We need to give the patient fluids to increase his fluid to replace the missing fluids. We need to give him good nutrition so the patient can get back his strength a little bit. And albumin, pre-albumin needs to be corrected. The antibiotic therapy. Now we need to prescribe the good antibiotic therapy. Now the main management for an infection is surgery. Antibiotics are only indicated as an adjunctive treatment. We use it when it's indicated. When is it indicated to go for antibiotic therapy? If we have fever, swelling, lymphadenopathy. So in these cases, we need to prescribe antibiotics. Antibiotics are indicated in these cases. Now, the risk of antibiotic resistance is high. It's increasing every year. Now, amoxicillin or clavulanic acid sometimes doesn't work. The bacteria is resistant to it. Metronidazole sometimes it doesn't work, and so on. So the presence of one or more penicillin resistant organisms has been increased since 1991, 33% to 63% in 2017. Clindamycin, 13.7% in 2006 to 32% in 2017. It's increasing, it's not decreasing. Now, other indications is swelling beyond the alveolar process, cellulitis, trismus, lymphadenopathy, fever, pericoronitis, osteomyelitis, immunocompromised patients. But given that we need to give the patient this antibiotic therapy after surgery, we cannot just give him the antibiotic, tell him wait a few days and come back. No. If we find pus, we find the swelling, we extract the tooth, we do the procedure that we want to do, and then antibiotics. Not just antibiotics and come back. No. Now, we have three principles: empirical therapy, prophylactic therapy, and therapeutic antibiotics. Now, empirical therapy, this is when we have the patient in front of us and we did the procedure, we want to prescribe antibiotics, but we don't have the actual antibiotic that's working on this bacteria, meaning the culture and sensitivity results have not been available yet. So what do we do in this case? We give in the most commonly working antibiotics, meaning in the oral cavity, we mostly amoxicillin or clavinic acid can be working, so I can prescribe it until I get the sensitivity results, the culture results. I will give therapeutic antibiotics, the antibiotic that works against this bacteria. So empirical therapy is the antibiotics or the therapy that we initiate before the final results of the culture and sensitivity have given the actual antibiotic that works on this infection. Therapeutic, once I had the antibiotic that should work, I prescribe it. Prophylactic, before a procedure. Before I'm doing a procedure, I give the patient prophylactic antibiotic beforehand. Now, in an outpatient clinic, we can give the patient penicillin, clindamycin, azithromycin. We can give azithro, clinda, moxifloxacin if the patient has penicillin allergy. In an inpatient, we can give ampicillin and sulbactam, ceftriaxone, clindamycin, ampicillin with metronidazole. We can do collection of antibiotics. We can do combination of antibiotics. We can prescribe two antibiotics. The one that works on gram positive and one that works on gram negative, one that works on aerobic bacteria, one that works on anaerobic bacteria. Now we need to administer the antibiotic properly. So, oral or intravenous, some antibiotics work the same, orally or IV. Some work better IV than orally. So, we need to know the antibiotic that works good on IV situations. We need to evaluate the patient frequently, every day, every 2 days. If he's inpatient, we would have see him every day. If he's outpatient, if he's inpatient every day. If he's outpatient, every other day. Now we can prescribe CT, we can order a CT scan, we can repeat the culture sensitivity to see the infection progress. Now, why would the treatment fail? Either inadequate surgery, we did not reach the proper spaces that we're supposed to reach, foreign body being present, either glass, after trauma, or whatever, depressed host defenses, the defenses are very low, antibiotic problems, patients not compliant, drug not reaching the site, drug dose is very low, wrong bacteria diagnosis, wrong antibiotic. These are causes of the failure that we might see. When can I change an antibiotic? If the patient has allergy to it, toxic reaction, or intolerance. Culture sensitivity test gave us the result that this patient should not take this medication. Failure of clinical improvement. Removal of odontogenic cause. Adequate surgical drainage. Other causes of failure ruled out 48 to 72 hours on the same antibiotic and the patient does not get better, we can change the antibiotic. Now, should we prescribe corticosteroids in these patients? Now, usually, we need to prescribe it as adjunctive treatment because it will reduce the swelling, it will reduce the pressure on the airway. Now, the surgical management itself will increase the swelling around the airway. This will put the patient under the risk of prolonged intubation or tracheostomy. So, it's still controversial, but it can be helpful. A single dose or a short-term dose of corticosteroids can be very helpful in these patients. And hopefully you enjoyed it. It's a very short lecture. Just I wanted to point out the important stuff on what we do. And these are the references if you want to look at them or go deep into them. And thank you.